Good morning, everybody. Thank you so much for joining us this morning. We are fortunate to have four really wonderful presenters here with us today. I want to begin, as we always do, just talking a little bit about what we've been doing, what's going on. As many of you have, and I see that we're joined this morning by Representative Lewis. I know he's been to some of them. We've been across Middlesex County attending some events in recognition of International Opioid Awareness Day, which was actually August 31st. And then we have up next, today's the 19th, I guess, in 2 days, National Opioid Awareness Day on the 21st. And, you know, as I always say, and I believe really strongly in this, people die once when they leave this earth, and they die a second time when people stop remembering them and saying their names. And people being out, putting out those flags, talking about their family members, that's just a really important part of this work. And it reminds us in a very visceral way of the kind of grief that this plague has really caused across our county and across our country. And I know for me, sort of fuels me in doing the work as we go forward, and really a chance to reaffirm our commitment to all of this. You know, and as all of you know, every month I report where we are in terms of the number of fatal opioid overdoses that we have responded to across this county. And I am almost afraid to talk about where we are today, because I don't want to sort of tip the favorable scales. And again, remember, I say all the time, one death is too many. But when we think back, and I know many of you were here with us in the beginning, the first 3.5 years that we were doing this work, no matter how hard we worked, we could not turn the tide. And since then, and really in partnership with our legislative partners, our law enforcement partners, our healthcare partners, we really have made an enormous difference here today. And right now we stand over 3/4 of the way through the year. And for the very first time, the number of non-suicide opioid related deaths that have occurred across this county of 1.8 million people stands at below 100. We have never been there before. And we're pretty deep in the year. And we also know, not that we won't continue to have losses, but the bulk of our losses usually come during the summer. So we are past what is for, you know, because we really track in terms of months and days and when in the day itself things happen. So we know that number gets bigger in the summer. So to get to this place in the year and be below 100 is really a testament to the partnership and the work that's been going on here. What we continue to see that worries me a great deal is that despite that over 20%, almost 25% decline that we have seen, the number that is not declining. Oh, and we're joined by Representative McGonigal as well from Everett. I'm happy to see him too, another great legislative partner. What we continue to see going up are what are deaths by suicide with the use of opioids. And remember, our bar for saying that something is a death by suicide is very, very high. We do not classify it that way unless there is really inescapable information that we have, a note, something that's a telephone message, something that indicates what happened there. That number has gone from 9 to 13 in the same time period. That's a big increase. And as I always say, and I was really been struck by it looking at the purple flags at these events, if you conservatively take that every flag, that death has impacted at least 10 people. And really it's many, many more people. Every time we do this work and we reduce those numbers, we just so greatly shrink the number of people being impacted in that way. And that's what all of us have been able to do here. And I am incredibly grateful to have you as partners. And what is concerning to me, though, and where I think, and that number, you know, getting below 100 is something I never thought we would be able to do when we were up in the 300s and 400s. But what does concern me is that we are seeing younger people. And if many of you were with us in the beginning, when we really made the decision that we were not going to make policy or choices around opioids, which we really didn't know a lot about, without hearing from the people who had struggles with addiction themselves. And so we brought together people who were in pretty solid long-term recovery. And we called it sort of a roadshow because it was a mobile policy forum. We took it all over the county and we talked about people from every economic group, every racial, ethnic group. They were diverse in all possible ways. What was it? Where could we have intervened? Where could we have helped? And what we consistently found was that the universal piece that people identified was some unaddressed childhood trauma. And the two biggest unaddressed childhood traumas were a divorce, even when it was an amicable, nonviolent, really did not result in an economic change or a life change for that child. So many people told us they were never able to really get their footing again after that. And the second, which is much harder to even try to prevent or address, was the death or the chronic illness of a sibling. Totally understandable. You lose a child, you have a child that's got a chronic illness, all of the air in that family is sucked out and directed in that way. And children who said, I just couldn't find my space. I lost my parents. I maybe lost my sibling. Everything revolved around, as it had to, the physical care of my sick sibling. And so we've done so much work, our Project Care, all of the prevention programs we've been doing with kids. One of the things that, and I'm sure many of you saw this, in the most recent school shooting, we had the two children lost their lives, the two teachers. What struck me, as I'm sure it did for some of you, was as they continued to interview children, and they were little, some of those kids were 11 or 12 years old, talking about seeing their teacher bleeding out in a hallway, talking about huddling on top of each other in a classroom. One little girl talking about that one of the children who lost their lives was somebody she rode the bus with. And I think about the world, and it's not just that, but how much trauma are our kids being exposed to? And can we really be surprised in a couple of years when we see, not every one of them, obviously, but some proportion of those kids struggling with addictions? And I think that's the next piece of our work. And we're doing the same with kids on our campuses. We're fortunate to have 21 colleges and universities across the county. We know, every one of us who either has been there or has kids, college is a hard place. It's a hard place for kids who are either trying to find their way. Maybe they came to campus with some struggles. Maybe they're in recovery. And we are working with those colleges and universities to really be better identifying kids that are at risk. We know that 27.8%, so over 1 in 4 kids in college, meets the criteria for a substance use disorder. And what kind of services, what's happening there? That percentage, interestingly, that 27.8, is higher than for any other age group. And we see that reflected in the losses we are seeing to an overdose. It is often people, especially at the tail end of that age. There was an article recently, we put that in the chat, published by Insider Higher Ed, that emphasized colleges really reevaluating their on-campus resources and their programming. We're long beyond where just substance-free dorm housing is going to make it work. Colleges need to be doing a lot more than that. And the White House has also released a strategy, released it in May, a strategy for colleges and higher education. So we're engaging with our council across those schools, trying to really force them to be thinking about those issues and what are we doing for that. I'm going to hear from one of our speakers about that today. So we're going to turn now to our first speaker, somebody who is an old friend of ours. has been a wonderful partner. She's been engaged with us for so long in this work. Dr. Barabelt, who is an anesthesiologist, a pain management physician, a researcher, an educator, an advocate. She's really been recognized as a leader in pain education and pain management stewardship. She is the medical director of Newton Wellesley Hospital's Pain Management Service. She pioneers a team-based pain care for patients, and she leads the efforts at Mass General Brigham to inform system-wide substance use and pain management initiatives. And she tells me her presentation today is going to reflect that kind of forward thinking. She co-founded the substance use services at the hospital. She promotes local and national best practices in co-managing pain and addiction, as well as the public awareness campaigns. And she is the president-elect of the American Academy of Pain Management. And as I said, Dr. Barabelt's been a partner in us with this work since the very beginning of our task force at Newton Wellesley. I don't know how she has time to do what she does. As you can see, she's actually in a treatment room right now. We never invite her to anything that she is not there. She's running the Purple Flag program out at the hospital. Just amazing advocate in this area. So I'm really happy that you've taken time to be with us this morning, and welcome once again.
Thank you, DA Ryan. I'm always so pleased to be part of this team. I remember when you all came to Newton Wellesley Hospital for the first time. It may have been 2017 or 2018, and I thought, how would a physician partner with the legal system? I first had that gut reaction of, I'm not going to talk with you. And here we are. I have learned so much from your team, and the people you have put us in contact with will be a testament to today. I'm intentionally being a little bit edgy, and I just want to put my disclosure here that these views are reflective of me and not my institution. But one of the people that DA Ryan put us in touch with is Natick Soar, and these are some of the unbelievable women who lead this organization. The Purple Flag displays in front of Newton Wellesley Hospital until Sunday morning. And I do hope that you will come by, because it is not, as DA Ryan said, yes, it is a chance for us to recognize and honor each individual life in Massachusetts that we have lost. But it's also a moment of celebration of these lives. And I feel a symbol of hope. And this is the first year, and you may have all heard the story yesterday on the news, that we are seeing a decrease in deaths related to opioids. And that is a good thing. Our team is led by Katrina Armstrong here with her son, Rory, Katrina in the red sweatshirt. And we really do have an amazing service. So please do spread the word if anybody needs our support. So what I wanted to do in this brief time is to really say, to call out what I think are some of the controversies and possible solutions to thinking about chronic pain in the United States in the context of the opioid crisis. And so our first controversy that I wanted to bring up is that our fear of opioids has led us to being afraid of treating chronic pain. And when you think about how many people suffer from chronic pain, perhaps you do as well. My mother has chronic pain, which is why I'm in this field. But if 1 in 5 Americans has chronic pain, and up to 40% of Americans on a daily basis have some sort of acute or chronic pain, that's more than diabetes, heart disease, cancer combined. We're really looking at what I would call is sort of a disease epidemic. And so we hear so much about opioid crisis, and of course it's unbelievably important, and we have learned so many lessons from our mistakes. But we're also in a pain care crisis, where again, I feel that our fear of opioids is making us afraid of treating pain. And in particular, the most vulnerable populations are women, patients with low socioeconomic backgrounds, military veterans, and those in rural areas. So we know the reality. We overprescribe too much. This is true. But when I look at my colleagues, for instance, one of our orthopedic surgeons who does shoulder surgery, he used to prescribe about 60 pills after a rotator cuff repair. And now he prescribes 0 to maybe up to 3 to 5, depending on the patient. So we've really done a different, we have a much different perspective of sort of what patients might actually need. That said, I did have a friend who just had a tooth pulled last week. She got 15 pills of oxycodone. She said, what do I do with this? All I needed was some Tylenol and some acetaminophen. So our opioid prescriptions still are on the decline, which is a good thing. But how are we preventing our patients from transitioning to other substances like heroin and fentanyl when opioids were really our sort of go-to for so long? And not all prescribers or doctors were evil. Honestly, we really just wanted to do the right thing. And many physicians and many prescribers didn't understand the really high risks of these medications. So then came along our CDC guidelines in 2016. And the goal was to really provide a framework for prescribers, for doctors, physician assistants, nurse practitioners, anyone with a controlled substance license for prescribing opioids. But the backlash was unfortunate. And so it was revised in 2022 as a response to what happened, which I'll briefly review, but I would argue was maybe 6 years too late. Because what we saw was this pendulum swing in pain management, where all of a sudden people would just say, oh, opioids, they're really bad, they're very harmful, you shouldn't be on these, they're not indicated for chronic pain. And so patients were being abruptly stopped opioids. I remember in the state of Maine, there was a legislation that said that anyone over a certain milligram equivalent of morphine had to be tapered. There was no consideration taken into sort of who the individual was and also the doses of the medicine and the potential dangers of stopping or even decreasing. So I wrote this op-ed in Stat News 2 years ago, and it definitely caused a little bit of controversy. But I told about a patient of mine who ended up committing suicide because of his chronic pain. What I didn't share in this article, and one of the things that I never tried for him, he was 27 years old. He severed his sciatic nerve in a car accident and had severe, severe leg pain, wanted his leg amputated. And again, then he killed himself with a gun. Is had I prescribed opioids, and the reason why I didn't was actually he had very, very strong risk factors, a long history of depression and anxiety prior to this accident. And I knew that he would have a lifelong of chronic pain. So the idea of starting an opioid in this young person with so many risk factors was really something that I didn't necessarily want to do. But again, it was always this thing in the back of our minds, especially as physicians, is opioid prescribing the right thing? But does that again lead to this sort of fear of treating pain in general for non-specialists like me? That I think is unfortunately the case. So another colleague of mine from medical school, we wrote this article in the New England Journal of Medicine that really highlighted about what the risks of abrupt or forced opioid tapers are. And so when the 2016 CDC guidelines came out, a lot of people just stopped prescribing. In this case, we talked about my colleague's patient who has sickle cell disease, which is a really actually life-threatening disease when you are in a sickle cell crisis. And he was on high doses of opioids to control his pain and had a urine drug screen that was positive for cocaine. So his prescriber stopped prescribing, and that put him into this terrible pain crisis. He ended up in the intensive care unit. So what does these sort of abrupt opioid tapers, even in someone who might be using illicit substances, potentially lead to? Well, it obviously can lead to illicit use or using street drugs that are potentially harmful. That can lead to a higher risk of overdoses, mental health crises, emergency department visits, death from suicide. Many of you may have seen some of the articles, including in the New York Times, that highlighted patients who took their own lives after their opioids were stopped. Another colleague put in a very controversial article into the New York Times just this last March, I believe it was. Yes, March. And there has been a big backlash on patients who are taking opioids for chronic pain in regards to production, and the DEA has put limits on opioid production. Again, all of these are in the benefit of our communities and our society as a whole, but you have to remember that this is impacting individual patients. And she talks about her mother dying of cancer, her mother-in-law dying of cancer, and who was unable to get opioids because of the DEA limitations on manufacturing. So what are our solutions? So here we are, right? We're in the middle of still a crisis, even with rates of overdose deaths on the decline. And we will never be out of this whenever there still are people who are dying. But we also need to think about the landscape of chronic pain. And when 1 in 5 of our US citizens is suffering from pain, what are we doing to treat pain otherwise? There's so many wonderful things that we can do and that we do here at Newton Wellesley Hospital. I have an incredible team, but we all know that pain care is so much more than a prescribed pill. But just because we might be afraid of opioids or the harms that they can cause doesn't mean that we can't treat pain. So it's about all of us to work together on our advocacy and messaging, that even if someone is prescribed opioids for chronic pain doesn't mean that they're addicted. Although there are higher rates, of course, of addiction to opioids for prescribed medicines, probably around 10 to 20% of patients who are prescribed opioids may be addicted to the medication. That still doesn't mean that chronic pain and addiction are the same. And really, we can see improvements in managing pain. So pain management is so much. This is my procedural suite. Of course, injections are only one part of the puzzle and not the gold standard, but it really is kind of, as I tell my patients, throwing the kitchen sink at our patients. And we want to use a collaborative plan that works both for the patient and the family. And if someone does have a history of substance use, that doesn't mean we can't manage their pain. It just might mean different things when it comes to the medications that we might choose or the monitoring that we might need to do to keep someone safe. And we have to balance that with what are someone's values, what does someone want, what are their financial constraints and potential hurdles or fears. Obviously, not everybody wants to try something if it's either expensive or maybe they don't even know how to swim. So why would I send them to a pool therapist, right? So we have to make that work based on our patients' values as well as the tools that we have. When I think about pain management, it really is multimodal and it really takes that team. And it's up to us to be talking about these alternatives so that we change the sort of general society thinking, which has always been there should be a pill for that, to really about, okay, what other therapies are there that we can consider? And there's many non-pharmacologic approaches. I would have liked to applaud Cindy Steinberg, who is a patient advocate who's been able to pull through legislation that makes it so that insurers actually cover some of these non-pharmacologic approaches. There's many non-opioid medications for pain that we can also offer to our medications, although medications really are limited and many come with side effects. And what are the role of opioids in managing chronic pain? Well, it is individual. It hasn't been in large population-based studies shown to really show an improvement in function for most chronic pain disorders. And there are physiological and neurologic side effects, which is also a reason why we can't just abruptly stop opioids or we can't abruptly force a taper in certain instances. When someone has a substance use disorder or an addiction to the opioid, the conversation really is different. But again, we start opioids much less readily than we did 10 years ago for patients with chronic pain, but that doesn't mean that opioids are evil or bad for patients with pain. And there is a distinction between when you're tolerant or dependent versus you're addicted. Tolerance and dependence means that you need higher doses to get a pain effect, or if you take the medicine away, you're going to withdraw. But that doesn't mean that someone is addicted. So we need to keep our patients safe while also maximizing those alternatives. So controversy number 2, and I have 3, is that team-based pain care really does work and it saves money. But we're still struggling. I have to say in Massachusetts, I feel like we're in a much better situation. But when we look across the country nationally, many health insurers are not paying for access to team-based care. And a lot of physicians are spending their time trying to get prior authorizations, having discussions with insurance companies to advocate for their patients. And some people are just simply giving up. So this access is just not available for all. And the disparities in pain care in the United States are really very apparent. Some of it's iatrogenic, meaning insurance-based. Some of it's geographic, where you live. So you may not have access to a physical therapist. Or iatrogenic, if it costs $100 to see a physical therapist or nutritionist, how can someone afford that? And of course, there's so many other socioeconomic and racial factors that influence healthcare disparities, in particular when it comes to chronic pain access. So I was proposed that we do what we're doing now and we work together. And it's not that insurance companies are evil or that, we need to do something differently sort of in the healthcare system. We know that healthcare is really struggling and we have a lot to do to really transform this behemoth. But that said, we can still do things together. And I think we can do that on a local level, probably more so than, and more effectively than we can on a national level. And a lot of people hear about the buzzwords artificial intelligence or digital health. These are not things to be afraid of. These are things to embrace because they are going to improve access of our patients to really great resources. We just have to work together to understand what resources are good and what are the things that can help our patients effectively, what's based in science, and what are really, I think, going to improve our patients' quality of life. But if a patient's waiting 2 to 3 months to see a doctor, what can we do in between those visits to be able to help them to move and to make sure that the care is also personalized? So our final controversy speaks exactly to what DA Ryan said before. So it's really about looking at our youth as well. So what are we trying to prevent? How are we trying to prevent chronic pain in America? We have an aging population, and that we do not have. So whoever's going to figure out how to reverse osteoarthritis is going to win the Nobel Prize. But how can we necessarily think about pain not at the time of suffering, but also preventatively? And I heard this beautiful presentation, and I wonder, DA Ryan, you might want to bring them to a future meeting, but by Waltham High School students, that this is a national survey through the CDC, and they look at risk behaviors in regards to mental health. And the three things that promoted resiliency and that have been seen not just in Waltham, but also in regards to prevention of suicidal ideation as well as depression and anxiety, but is to have a trusted adult in school, to have a trusted adult at home, and to have extracurricular activities. Obviously, too much, as I know with my kids, is not necessarily good, but to be able to get your heart rate up, to do athletics, to do sports, really promotes resiliency. And I think that if we change our system so that, again, we're not always looking at, okay, fixing something when it's broken, but how do we help people to understand that investing and reimbursing for preventative medicine and promoting healthy living can actually have unbelievable downstream consequences on our community's quality of life. So 1 in 5 adults have chronic pain. We know that team-based multimodal pain care works, and I didn't share the science with you, but I'm happy to for anybody who's interested in it. There are lots of strategies that we also use at Newton Wellesley Hospital and through the Mass General Brigham system for safe opioid prescribing, and we're doing a better job. But it is indicated for certain patients for chronic pain, and we can maximize ways to, again, ensure that that our patients' risk factors are mitigated. Pain and addiction are not the same thing, but they can co-occur. And we know that a large percentage of patients with addiction also suffer from chronic pain. And we also know, again, it is so common. And this is very, very rewarding for me. But I can't do this alone. And I'm so grateful to Dr. Armstrong and the Substance Use Services team, which we co-founded back in, I think, 2015, in response to the fact that our patients needed more. And we needed to really be able to rely on each other to support us when managing chronic pain and managing addiction can be, of course, challenging, but it is possible. And if we can work together to improve access to both treatment, but also preventative strategies for our patients, I think we're going to make a huge difference in how we treat pain in the United States. So with that, I want to say thank you.
Thank you, Doctor. Wonderful information as always. And you're right about those Waltham kids. I was with them when they launched that project. And just think about it. Like, it sounds so simple. Every kid should have a trusted adult in their house and a trusted adult at their school and have something that they care about that they do. That's really not a lot. And yet the impact of that and the number of kids who don't have that is what we're seeing. And that really is, I think, the next frontier for our work. So, and clearly, Dr. Barabeld and I have been doing this together so long. We did not talk about this at all, but it was a perfect segue. So thank you so much for being with us. We turn now to Dr. Noel Best. Dr. Best is an assistant professor at BU School of Public Health. As a formerly incarcerated scholar, Dr. Best advocates for social justice issues and public policy around addiction, substance use disorder, and prison reentry. His research interests include mental health, substance use disorder, poverty, social justice, addiction, recovery, and pain. He was recently the recipient of a KO1 Early Investigator Award through the National Institute of Drug Abuse to study collegiate recovery programs, which I mentioned earlier, through an implementation science lens. He received his PhD and his master's degree in experimental psychology from Washington State University, and he recently finished a postdoc in the Department of Anesthesia at Stanford Medicine. So, Doctor, thank you for being with us this morning and talk about both your research at the national and the local level.
Yeah, well, it's wonderful to be here. Just want to take a minute to thank DA Ryan and Megan and Emily and everyone kind of involved in inviting me here today. I think that, you know, these types of presentations within the justice system are especially important for me because, as DA Ryan alluded to, you know, I too had an addiction mainly in my 20s after high school that led to a 7-year prison sentence. And so it's really very, very poignant, I think, for me to be here today and truly a kind of one of those full circle moments. So I'm very, very thankful to be here. What I'm going to present today is some of the results from my KO1 or Early Career Investigator Award through NIDA. This is just one small project of, you know, many different papers and projects that have kind of come out of this. But I'll focus on one that kind of talks about the criminal justice system or delves into criminal justice involvement amongst collegiate recovery program students. But please feel free to reach out to me if anyone wants to talk about this. The last slide I have will have my email address, and I'm more than happy to have a chat with anyone that would like to. I think it's really important first that I kind of explain what collegiate recovery programs are. And though I could never cover what they are in such a short time frame, I will give kind of just a brief overview. So a brief overview is that they are really any resource that you could imagine for a college student in recovery. And you know, what by recovery, I mean a very wide swath of the definition of recovery. So it's not recovery just from substance use disorders. It would also be, you know, potentially recovery from eating disorders. It would be recovery from mental health issues. And, you know, ideally kind of some of these peer-based recovery supports that, you know, that we have kind of become familiar with. And so I'll talk a little bit about a few of them and then kind of give, again, a brief overview. So I think the most well-known collegiate recovery program is at Texas Tech University. It's a very resource-rich. They work from a $40 million endowment, and really everything revolves around this building that they have. This is their student drop-in center. It's a 3-story building. They have multiple mutual health meetings, AA, NA, All Recovery, Celebrate Recovery, all different nights of the week. They offer, as you can see here, sober tailgates for every Texas Tech home football game. And then you can imagine with a center like this, a drop-in center like this, that, you know, they have a very rich peer support system that really works to, you know, provide that support for students in recovery. This is the Well House at Stanford University. This program really revolves much more around what's known as the Well House, which is a substance-free housing unit, where about 30% of the individuals living there identify as in recovery. I'm very, very familiar with this model and this program, as me and my wife were the inaugural resident fellows while we were at Stanford. So as you can imagine, these two programs are very well funded. And I would say that they are actually exceptions to the rule. Most schools are very lucky to have a mutual help group on campus, or perhaps maybe a few substance-free activities that are sponsored. But nothing to the level of this, and most kind of fall somewhere in between. At this time, according to the Association for Recovery in Higher Education, which is kind of the governing body of these programs, there are 154 recognized programs across the country. There are 3 currently listed in Massachusetts. All are in Boston. There's one at Boston University, there's one at Boston College, and there's one at Tufts University. And so that just kind of gives a brief overview. As far as a background on collegiate recovery programs, as everyone can imagine, already kind of been talked about, college substance use has long been identified as a strong indicator of adverse public health outcomes. It's estimated there are about 600,000 students in recovery, college students in recovery. And as we know, colleges can be a very abstinence hostile environment. And so I think, as we'll get into here in just a minute, colleges and universities are, with these collegiate recovery programs, I think are kind of uniquely positioned to be a solution to both the addiction crisis and to mass incarceration. These next few slides, I'm sure that people are on this call are very, very familiar. So I'll probably kind of breeze through these slides, but we know that mass incarceration is likely one of the most important public health issues that we've had in the last 50 years, fueled by many, many different political things, tough on crime stances. You know, we've just seen a huge increase in jail and prison populations. And so there are currently about 1.9 million people. This is actually great news, honestly, because this is actually down from about 2.2 million pre-COVID. This information comes from the Prison Policy Initiative. And you can see kind of the breakdown of the individuals in local jails and then in state prisons. And along with these stays and being incarcerated, obviously a lot of these people that are coming out are affected by the collateral consequences of that incarceration. So there are 79 million people in this country that have a criminal record, and as you can imagine, these collateral consequences are very, very profound. So we have limits on housing, limits on jobs, limits on voting rights, just to name a few, limits on, you know, being able to apply to and get accepted into college. And, you know, like I say, I'm very hopeful that studies like these can be kind of the first important step, or kind of help to uncover solutions to mass incarceration in this country. And again, I don't have to tell anyone on this call, many people that are involved with the criminal justice system, whether it's people in state prisons or people in jail, have much higher rates of substance use disorder, especially when you compare that rate to the general population. Again, just kind of painting the broad picture of kind of some of these underlying issues. We also know that there are many colleges out there offering prison-based education programs. Not all of these are the same. Not all of these are credit-bearing, but there are many either certificate-bearing or credit-bearing schools. As of 2021, there was 396 college and prison programs, and each of these purple dots kind of represent where those college and prison programs are. Recently, as many people know, in 1994, the crime bill that was passed eliminated Pell Grants for people in prison. Recently, that was overturned with the FAFSA Simplification Act in 2020. And so this is expected, obviously, to increase further college and prison programming. And I think as an extension of that, you know, students that are going to be leaving those college and prison programs will be looking to transfer to 2- and 4-year institutions of higher education outside of prison. And I think that, you know, a case can be made that colleges and universities that are uniquely, I would argue that the ones that are kind of better prepared are really going to be uniquely positioned to be kind of a solution to these intersecting epidemics of mass incarceration and addiction. And so this study was really interested in the intersection of these three problems, right? So addiction, reentry after incarceration, and then what colleges should know regarding the potential influx of students. And so the rationale for this study, there are many studies out there that show that people coming out of prison that are able to attain a college degree, the recidivism rate goes down with each level of educational attainment achieved. So associate's degree, it goes down, master's degree, or bachelor's degree, it goes down further, master's and graduate student or PhDs, the person has roughly the same amount, same recidivism rate as just the general population of going to jail. And so we know that these can reduce recidivism extensively. And so in this particular study, we hypothesized that these students with incarceration would differ significantly from the other students on measures that are kind of associated with higher levels of recovery or improved levels of recovery. And so to say this kind of in layman's terms, we expected the individuals kind of coming out of prison or with criminal justice system involvement in these collegiate recovery programs to have a more high-risk profile, if you will. And so the methodology for this study, this was a study, secondary data analysis. The original study was collected as part of a program or part of a research program at Virginia Commonwealth University. There were 435 total participants. We used the baseline data only, so this is not longitudinal. We just kind of get a snapshot of what these individuals show up with, some of these characteristics that they show up with to these collegiate recovery programs. These are some of the partners that VCU had. So these were some of the schools that they collected the data from for this particular study. This will be the only somewhat stat-y slide that I have, but just really kind of showing, within ANOVA, we're looking at differences between three different groups. So we pull from a national survey of collegiate recovery program students. We have that student sample, and what we're looking for is differences between non-justice involved, people that were justice involved but never spent time in jail. So almost like a group that you could call a second chance group, I guess you would say, and then differences between the individuals that were actually formally incarcerated. And so this is a quasi-experimental study because we're putting these people into groups that are naturally occurring phenomenon and not randomly assigning them obviously into these groups. And so these are the outcomes, the recovery related outcomes that we were interested in. Recovery capital is what you kind of concern like a contextual variable that looks at some of the social types of resources for the individual while they're in recovery. The other ones there are kind of self-explanatory. And then we wanted to make sure that we controlled for age, gender, and race. We just want to make sure that we're not measuring something like age or some kind of confounding variable. I think an easy way to understand that is, Stats 101 courses often talk about the rate of crime going up as the rate of ice cream sales increase, right? We know that what we're actually measuring is the temperature going up. So we want to make sure, again, that we're not measuring some kind of third variable that is just kind of associated with both of these things. So we want to have these covariates of age and race. And so the results here, this is the demographics of students, are the age of this group of students in collegiate recovery programs is much higher than I would say traditional age college students, which range right around 23 or 24 years old. Much higher percentage of people that identify as really non-straight or heterosexual, non-heterosexual individuals. Much higher rates of trans and non-binary in these collegiate recovery programs, about the same as what we see in college samples as far as racial breakdown. These are the control variables that we wanted to make sure we're not influencing. We had both age and gender being significant. So in subsequent analyses, we held constant these variables, and you'll see this. We do this in a kind of a two-step process. And so what we're looking at here, these are the measures that we measured. I already mentioned across earlier. So severity of substance use and alcohol use disorders, quality of life, recovery capital, grade point average, and then hours worked per week. Without controlling for age and gender, we see there are quite a few differences, significant differences between these non-system impacted, system impacted, but no jail, and then formerly incarcerated groups. But then when we control for both age and gender, those kind of third variables, we can see that the only ones that actually remain consistent are both hours worked per week and substance use disorder severity. So people that are justice system involved, having substance use disorders that are more severe, which I think we would expect. That's very in line with what we know about the criminal justice system in general, and people being associated with the criminal justice system having more substance use disorder problems. And then we see that these individuals are working quite a few more hours per week than these other two groups. So almost 26 hours per week compared to 14 and 16 hours per week for individuals that maybe had gotten a second chance or were non-incarcerated. And so what does this all mean? At least within the context of this particular study, I think that, and again, this is kind of reiterating what we found in the study, is that formerly incarcerated students may face greater obstacles to higher paying jobs and are therefore maybe forced to take greater responsibility to supplement their income. I think that these responsibilities have the unfortunate potential to interfere with valuable time that should maybe be devoted to their studies. I think the second thing is that, these formerly incarcerated students have higher SUD severity or substance use disorder severity than their non-incarcerated counterparts. And then as far as administrators and providers, I think that understanding that these students may be working more hours and have drug use symptomology that is more severe, I think helping them to secure financial aid or scholarships or find maybe even additional support in the community as far as AA meetings, maybe local AA meetings or mutual help meetings, all recovery meetings, smart recovery meetings may be vital to their success. And again, as I mentioned, anyone that's interested in learning more about this paper, I'm more than happy to share this paper. I'm not sure that it's publicly available yet. It is out there with, as long as you have a subscription to Elsevier. But if you want a copy of it, I have a copy of it that I could definitely send out. And so with that, I'm done. I can definitely take any questions. I will stop sharing. My email is incredibly easy to remember. I'm at the School of Public Health in the Community Health Sciences department here at BU. So just best@bu.edu.
Questions, comments? Kim, did you have a question? No, okay. Stay straight hand there. Oh, Susan?
Yeah, I have a question. I was wondering, did you also follow the specialty recovery courts? I mean, they really have, up their game, and I've attended quite a few courses that have incarcerated people now involved, like in the CPS, especially classes. They tend to go into that course level and graduate into it. And so I was just wondering, did you include that in the study?
So, and again, this is secondary data, so I didn't actually collect the data. So we just basically ran an analysis on a data set that was already collected. I can say for the study that I'm currently doing right now, and haven't quite finished tabulating all the results, we did look at those types of variables, and we definitely will be reporting on them. I can't tell you exactly what we found right now because we haven't really dove into that data, but a very important part of it, I know that, you know, Texas Tech works very, very closely with their local communities of treatment centers and with the both the drug courts and all kinds of court systems. Programs work differently, I would say. If you understand one collegiate recovery program, you really understand that one collegiate recovery program. And it really does look so different across the country. But there are definitely examples of that I've seen that do kind of integrate those two things.
Anybody else? Questions, comments? Doctor, thank you. Thank you for being with us, and thank you for that information. Now, excuse me, now we're going to turn to Han Hogan-Rigg, who has spent almost 10 years working as an educator in the Middle East and in the United States with both high schoolers and adult learners before she joined Fenway Health as a case manager. There, they worked with mostly patients living with HIV and substance use disorder. Currently, Han works with the harm reduction community health as a harm reduction community health worker in the newly formed CHW office for Somerville High School. Close to my heart, always. I'm from Somerville. It's a community that has really been hit hard by some of these issues and has equally taken the lead in addressing a number of them. For the past 3 years, they've worked with the music festival in Portugal, doing harm reduction work, promoting safe substance use with the attendees, and responding to substance-related crises during the festival. And Han joins us today to share Somerville's efforts, and as I said, they've really been at the forefront of a lot of this, to expand prevention efforts and training. So thank you for being with us.
There we go. So it looks like my internet's a little,
Yeah,
a
we
little
can hear
fuzzy
you
right now. So if I vanish, I apologize for that. All right. All right. So today I'm just going to be talking a little bit about a kind of new project that we're starting in Somerville. So first, just to review, my name is Han Hogan-Rigg. I'm the harm reduction community health worker in Somerville at our new office of community health workers. So as part of that, I do like general community health work, so like food access, mass health, resource assistance, community outreach. But I also work in prevention, doing like harm reduction trainings, overdose prevention trainings, naloxone distribution, and then harm reduction supplies and outreach, which is what I'm going to talk a little bit more about today. So generally, test strips are a pretty simple tool that are easy to use, and they're relatively low cost. They're part of our distribution efforts, part of a lot of places' distribution efforts, and they're seen as kind of an easy way to just try and get people to make their drug use a little bit safer. And so here you can see like a wallet card from the Mass DPH Clearinghouse. I'm kind of imploring people to test their drugs. And this makes sense, right? As we can see just from this graph from the Massachusetts Drug Supply Data Stream, this is the increase of xylazine in fentanyl over time in Massachusetts. So you can see it's a risk factor. Just like fentanyl in stimulants, the drug supply is not safe. But effective outreach around adulterants can be kind of difficult. It can be hard to warn people about the high risk of xylazine, for example, and their fentanyl without making it sound like all fent has xylazine in it. Xylazine is also metabolized pretty quickly, so it may not show up in a user's urine. And so like if someone isn't aware that they're using xylazine, they might not know to screen for those health risks, which include the wound, like pretty bad wounds, but also other things with blood pressure. It makes treating withdrawal much more difficult. So we try to kind of encourage everyone, right, be tested for your drugs. But there is kind of often a sense that xylazine is in everything, or that fentanyl is in everything, which really isn't true. Like certain areas do seem to have a higher prevalence of certain adulterants. And most street drugs, most street opioids might be fentanyl, but even for that, like there's been some user reports online from drug users in Vermont that some of the opioids have heroin in it again. So the drug supply is not stable. We don't always know what's in it, and we just really want to encourage people that they should be testing. People may also choose, though, not to test, not just for sort of like the there's no point type of feeling, but also they might not have an area to do it in, they might not have access to water. Also, if someone is unable to like kind of get a new supply of drugs, they also might feel like, why bother to test, right? Why test my fentanyl for xylazine if I'm going to be doing that fentanyl anyway? And I've heard kind of some anecdotal reporting of that type of thinking, both from providers and also from clients. But one of the things that I've realized when looking at our tester distribution is that we really don't actually know who is testing. We don't know what the results are. It's an individual tool, but it's not one that's really connected to our larger like data collection, as well as our larger like efforts to figure out if what we're doing is helpful. So right now, kind of the current test distribution in Somerville. So we have the distribution efforts at naloxone events and community-based organizations like Somerville Homeless Coalition, which is actually where I am right now. So I think they're in the basement, so that's why the internet's a little bad. And then also the backpack program that I'm going to talk a little bit more about a little later. But what we're missing are those second and third step of the tracking of strips. So like who is testing, how often are people testing, are there positive results, negative results? And then also that long-term impact of strips. So like behavior change. For example, if someone is testing their crack for fentanyl and they have fentanyl in it, are they maybe changing how they use it? Are they making sure to use with people? If someone finds out that their fentanyl has xylazine in it and they normally inject, are they like changing maybe to smoking or changing to snorting? So we don't know if people are doing those things. And we also don't know if there's a community awareness of results people are telling each other. We don't really have a system for publicizing those things. So that's kind of what we want to be working on right now. And just to kind of flag why those gaps matter is that, for one, if we do have a better sense of the drug supply, if we have a better sense of like what the test results are, we can kind of react to issues a little faster or even be proactive about them instead of kind of trying to play catch up, which I think is what has been happening for a long time. And then also this can inform us if we need better outreach, for example, to local medical providers about treating the withdrawal from someone that's coming off of xylazine and fentanyl, since you can treat like xylazine withdrawal, I think clonidine, but that's also going to affect how you're treating the opioid withdrawal. So if people aren't aware that xylazine is in there, that can cause some health issues, make it pretty difficult for someone. And then also kind of reducing substance use problems. If we have a good testing system set into place, we can also focus on talking to people about changing how they use drugs, because there are ways to make drug use safer, even if you're still going to be doing those drugs. And possibly at some point kind of building these efforts into more of a system of testing in Somerville that is not just giving people test strips. It might be like visual education where we have them use them, or if there's an FTIR machine or other kind of more in-depth testing things. And also fixing these gaps can help us develop a close relationship with the drug users in the community, more of a direct one between the city and the substance users, and just kind of establishing trust in the city as an entity that's trying to keep people safe. Not just those connections can also at some point lead to people maybe finding recovery if that's something that they want to do. So this is kind of a basic overview of the project. So we do have a new director of prevention services starting at the end of the month. So a lot of these details might change, but this is sort of the general thing. And I have talked to him, and he's kind of all for it. But so first, tracking the distribution. So asking like SHC, for example, having them fill out like when someone takes a test strip, all that, tracking the results. There's going to be gaps in that because there's going to be some self-reporting, and then soliciting feedback, going a little more deeply into people's thoughts around test strips. So first, right now we work with the Cerebral Homeless Coalition to implement the system, but I have so SHC tracking the distribution of strips when handing them out, not tracking people's like names, not tracking kind of identifying information, but just saying like right, so that we know if it's kind of just one person taking a bunch, if many people are taking them. At that time, we'll also have a brief optional questionnaire about just prior test use that people generally test. If they don't, there's behavior change, and we'll have like a small incentive for people to fill that out. And then asking clients to report the results back when they ask for new strips. So again, there's probably going to be some gaps in that third part, right? We are relying a little bit on people coming back to us. I am hoping to have maybe some of the testing, if we can do them like in a certain area, it can be tricky to set up kind of some of that, but we are hoping that people, when they get new test strips, will report back. And then kind of the larger part of this is integrating it into the backpack program. So the harm reduction backpack program was started by the previous prevention manager, Matt Mitchell, and basically clients at of SHC, and then also the Fenway Drug User Health Program can get these backpacks that have been filled with, they have like sleeping bags, they have harm reduction supplies, phone chargers, socks, hats. So it's kind of a fair amount of supplies in there. And until now, they can get them from doing a naloxone training. But just based on my own talking with clients, based on some feedback at Fenway, like a lot of people, pretty much everyone getting these already knows how to use Narcan. And so I think there's kind of a missing opportunity there for us to be doing some deeper engagement with people around harm reduction substance use. And so what we're going to be doing is using these next group of backpacks to have some deeper conversations with people around like why they do or don't test, like awareness around how to use testing, if people are aware of the ways that you can change your behavior to make your drug use safer. So I said earlier, if you normally inject, snorting instead, or smoking. And then also kind of seeing, do we need more outreach in certain of our like drug using populations? So for example, meth is a problem that we're seeing more of that did not used to be as much of an issue. And fentanyl is being found in it more often, partly just because the price of meth has dropped a lot in recent years. And so we're seeing more clients who are using it. And we're seeing also more fentanyl in it, which didn't used to be an issue. So is that community aware of the danger of opioids in their substances? Do we need more outreach to our stimulant users? And then also kind of that, again, that harm reduction behavior that can happen. So to kind of wrap up. So kind of the questions that we're hoping to answer here is just in our most vulnerable populations, who is using test strips and how often do they test? What barriers to testing exist, whether that's barriers around knowledge of how to do it, privacy, sort of preconceived notions around testing, if people are aware of how to reduce their risk if the substance tests positive and they still intend to use, are people practicing risk reduction strategies? Also more generally, what the Somerville drug landscape looks like. Right now, our idea of Somerville substances is based in kind of looking at that drug data for Massachusetts as a whole, looking at it for like Cambridge and Boston, looking at it for Middlesex County, but to try and get more specific information about just our city. Also, how can we communicate information about the drug supply to our residents? And then just are the test strip distribution programs as they currently exist accomplishing their goals? And then once we kind of answer those questions, we can develop some more effective messaging around test strips, risk reduction behaviors, drug warnings, lay the groundwork for future drug testing programs, whether that's in an OPC, whether that's in kind of a standalone like office with the FTIR machine and other technology for testing. Also creating more those direct relationships between the city and our drug using population. And then just understanding those Somerville specific issues to make sure that we're serving our constituents as best that we can. All right, I realized I did not put my my email there, but you can find me on the Somerville HHS website or just at hhoganrig@somervillema.
Thank you so much. Questions, comments? You know, and those strips and testing are important. I just remind people, we have lots and lots of test strips, fentanyl and xylazine test strips. I am happy when they go out the door. So please let us know if you're having an event and you want to give them out, you want to use them somewhere. We are happy to get them to you to distribute in communities. Any questions, comments? Thank you, Hen. Thank you. Now we're going to hear from Judy Bazinet, who is the program manager for Project North, and that stands for Navigation, Outreach, Recovery, Treatment, and most importantly, Hope. And Judy supervises a team of court-based recovery support navigators. She comes to this work with more than 10 years of experience in forensic social work, healthcare, and criminal justice. Before she joined the executive office of the trial court, Judy served as the director of addiction treatment services and clinical stabilization services at Spectrum Healthcare. She worked as a clinician in the Brockton and the Hingham drug courts and as a clinician at the Suffolk County House of Correction. She is a licensed independent clinical social worker and holds a master's degree in social work from Bridgewater State University. And then she's going to talk today about Project North's work. Really fits in so well with what we were talking about, the collegiate programs, the justice-involved folks. So thanks, Judy, for being here.
Thank you so much, DA Ryan and the Middlesex DA's office for inviting us to speak about Project North. We're very excited about this program. I'm just going to share my PowerPoint, then we'll introduce my team, and they can share a little bit about their experience. So as you said, Project North stands for Navigation, Outreach, Recovery, Treatment, and Hope. So Project North is a grant-funded program through the Department of Justice. It's a $6 million grant. Most of it is intended to go back into the community. The trial court retains $800,000. We're one of 11 states to receive this award, and we're the only court. We're one of the 11 states make up the comprehensive opioid stimulant and substance abuse site-based program. So our target population are court-involved persons with indications of substance use disorder. And our goals are what you would expect. We're hoping to increase treatment engagement, decrease risk of justice involvement, decrease risk of overdoses. So the grant was intended, it was a response to the opiate epidemic and the amount of overdoses. So overdose prevention and education is a big part of what we do. And our objectives are what you would expect, also to increase access to evidence-based treatment, increase access to care, help overcome some of the barriers to treatment, increase recovery resources and capital, and increase access to overdose prevention education in naloxone. So we like to say we have 3 buckets. So the main part of our program is recovery support navigation. We have 15 court locations throughout Massachusetts. This program's a little unique. A lot of our services are provided to district court. We're available to any court department. That includes Superior Court, District Court, Probate and Family, Housing, and Juvenile Court. The navigators are located in each of these courts and available to speak with anyone involved with the court struggling with substance use and looking for assistance. We have a transportation piece. We found that one of our biggest barriers to getting people to treatment was they had no way to get there, so we included that. And so we provide transportation using Uber Health. It's just a initial connection. It's not ongoing. And we also have a housing piece in which we provide up to 90 days of funding in a MASH certified sober house that contracts with Project North. We're actually at the end of that, but we still have a little bit left. We are working with UMass Memorial Medical on the data collection and evaluation of our program. This is just so you can see how we sit in the court. So I work for the executive office of the trial court. My immediate supervisor and co-director of the program is Marisa Hebel. She's the director of behavioral health for the trial court. And then we have the other co-director is the deputy commissioner of probation, Mike Coelho, who oversees the housing piece. We work with probation on the sober housing. And we have a grant unit that works with us as we're a grant program. We also work with UMass Memorial Medical on the data collection. And then all of our recovery support navigators are employed through treatment providers in the community which they serve. So eligibility for Project North. So Project North is a free, confidential, and voluntary program. It's not court ordered. We can't communicate with the court unless we have a release of information. It's available to all court users and family members. That's also pretty unique. Not many services are provided for family members also. This is like, a lot of this is around like a Section 35. A family comes in to section their loved one, and the loved one is either granted the section and goes to treatment, or else is out the door and the family member is left like emotional. It's a really crisis situation. So we want them to be able to talk to a navigator and get some support around how they're dealing. We had to define court user, and this was mainly around the housing piece. As you can imagine, we were inundated for requests for housing related to the homeless epidemic we're experiencing. So the court user was defined as somebody who is involved in the court in a Project North location within the past year in order to be eligible for the funding. That being said, if somebody comes to a navigator looking for assistance, we're going to help them as best we can, regardless of what location they're involved in. So what the Recovery Support Navigator is intended to do, so they're intended to help the individual facilitate access to an evaluation, treatment, and recovery support resources in the community. A lot of times, a judge will order that a client receive substance use treatment, and as part of their conditions, a lot of clients don't know where to even begin. So we're there to help make that connection for them. We're a short-term care. So we meet with the client, we complete an intake, and then we make that connection to care. It's not just, oh, here's a phone number, we make the appointment. If we need to provide the transportation for them to get there, we're willing to do that. We want them to make the connection. We also work with assisting them in adjusting any health insurance enrollments they have, any needs they have around that. If they're not connected to Mass Health, how can we get them connected in order for them to get the services they need? We make, every time we meet with a client, it's an opportunity for us to talk about overdose prevention in naloxone. So we let them know where they can get naloxone for free, and we talk to them about the risks of using and how they can stay safe. We also provide, we're a resource for the court. So a lot of times an attorney will walk by and ask us, hey, I have a client, can you tell me how to help them with this? And so we have resource guides that I'll show you later that indicate where all the services, treatment services for substance use in that community. So what navigators are not intended to do is testify before the court, report back to the court without a release of information, or influence cases. So this is just to show you where the navigators are located in Massachusetts. As you can see, we go from Pittsfield to Barnstable all through the state. And so these are the locations that a person is able to walk into a court and find a navigator. And these are the treatment providers who employ our navigators in Pittsfield and Springfield. It's clinical support options. In Lowell and Lawrence, it's Lowell House. Open Sky in Worcester, Manette Community Health Center in Taunton. Stepping Stone has the Fall River, New Bedford sites. Gavin Foundation is in Barnstable. Gandara is in Brockton. And Bay State Community Services is Boston and Quincy. And North Suffolk Mental Health has Chelsea and Lynn. And also we have another site in Haverhill. So this is really a great because all these providers are in the community, so that the recovery support navigator is already embedded in a treatment with treatment and knows all the familiar resources. So each location has their own resource guide, their own brief, and a navigator sits in the, ideally, the navigator sits in the court where they're located, with a sign that has with a table that has all kinds of signage, letting people know that they're available. Project North is here. Need help? Ask me about substance use treatment and recovery. No judgment, no stigma. We get a lot of people asking about recovery treatment based on that. Some of our navigators are located in the Community Justice Center, as some of our courts just don't have the space for them. But just if anyone wants to know anything about Project North, we're on the mass.gov website. You put Project North in and you'll find out everything you need to know about Project North. So we're working with UMass Memorial Medical on data. These are our intakes, and it was, we have REDCap. We have a intake that takes about 20 minutes. The navigator meets with an individual and goes over their history so that we can best determine how we can help them. We follow up with a client in 24 hours just to make sure that they made that initial connection to care. If they didn't, we offer to help them again. And then we follow up again in 7 days. And for people who are in housing, we follow up again in 30 days. So we have brief contacts. That's just people who are stopping to ask information about how different treatment options. And we have a recovery capital scale that we're in the process of developing, finding out what kind of resources would best serve those people. These are just some of the information we obtain in the intake to find out what services we need to direct the person to. Our primary focus is on substance use, but we know that a lot of people struggling with substance use also have co-occurring illnesses, so we do help people who are struggling with mental health. So this is just a little bit about the data. So out of the clients we serve, 93% of these individuals agreed to have us follow up with them. Of the 93% we followed up with, we made contact with 78%. And of the 78% of the people, 88% reported that they had successfully made connections to care. So I wanted to leave some time because I have two of my navigators here, as well as my administrative person from Project North. I wanted to give them a chance to introduce themselves, and I thought it would be, I think it's really beneficial to see how the navigators, like what their day-to-day looks like and who are some of the people that they're actually serving, so you can get a better understanding how Project North works. So I'm going to ask Tess to introduce herself first.
Hi, everyone. I'm Tess Jurgensen. I'm an administrative coordinator. I work in the executive office of the trial court. My background is in public health and public policy, and I provide some background project support to the awesome Project North team.
Thanks, Tess. And then I'll ask Avi to introduce herself.
Hi, everyone. My name is Avi. I'm the recovery support navigator at the Lowell Courthouse.
Thanks, Avi. And Natasha.
Hi, I'm Natasha Alba. I am the recovery support navigator sitting at the Lawrence District Court.
Thanks, Natasha. So Natasha, would you just speak a little bit about some of the people you've served and how it works, how it's worked for you in the Lawrence Court?
Yeah, so I've been at the Lawrence Court for about a year and change now. I've served an array of individuals, from individuals struggling with a substance use disorder and having justice involvement, as well as supporting the families, especially those that are coming in looking to do a Section 35 and are unaware of the proceedings, being able to provide them the support that they need, and educational pieces like educating them where to get Narcan. I had a mother, age of 60 years old. I guided her where to get the Narcan, and she ended up having to use it with her son, who was a previous client and unfortunately had relapse in their home. So the work that we're doing is pretty much planting seeds where we're getting individuals that are coming back continuously, even after receiving treatment, and that could be from utilizing sober home services or assisting an individual in finding treatment like detox or CSS or any additional services like completing a raft application to be able to continue to help them, or referring them to continuum of services like outpatient or educational or job trainings. So we do a lot of that, and day to day, I would get between lawyers, family members, and probation seeking services, as well as other community agents reach out to me. So we're just trying to make connections with other agencies so we could be able to reduce the barriers when we get a call or get asked to assist an individual in their treatment needs.
Thanks, Natasha.
Thank you.
Avi, I don't know if you had anything you wanted to add to that, but I want to give you an opportunity.
Yeah, very similar to same work as Natasha mentioned, also working very closely with the specialty courts, so attending drug court, mental health court, speaking with the clinicians. Sometimes they decide that they need treatment, so then we help them search for places. Also, attorneys come down and kind of talk when they're in lockup and they're trying to get their client not to serve any time and instead get them into treatment. So doing that process, which essentially is I would go down to lockup, speak to the client, talk to them about the different levels of care, what they're interested in, you know, what their past history is with substance use and recovery. Some of them have no idea any of these resources are available. So it's really like heartbreaking sometimes to see that they don't know anything. They break down because they finally see kind of like hope for them. They're like, oh, I've been in this cycle for so long and like I didn't know anything. I didn't know that any of these services were available to me. So so then after that, just like completing the application and like finding them a detox or a CSS or whatever is appropriate, and then the court needs a letter from them saying that, yes, they have a bed available, they'll be able to go. So then the attorney brings that to the judge and the judge ultimately makes the decision. Recently, I had a case where same thing, proceeding happened. And then a couple of days later, they went in front of the judge agreed, they put him on an ankle monitor and he has to go to a locked facility, but he was able to go to treatment instead of being locked up without any accessibility to any help. And he also had mental health problems, so it was very important for him to be treated for that as well, and making that connection with a mental health specialist or telling them places where they can call and resources that are available for them in the community moving forward.
That's great. Thanks, Abby.
Thank you all. Anybody have questions, comments about the program? For Tess, Avi, Natasha, Judy? No? All right. Thank you all for being here. Important new program.
Thank you.
Just want to give people an opportunity. Anybody have any programs they want to do, work they've been doing? I see Maureen Busby's with us this morning. She's been having great success in communities passing ordinances around banning the sale of tobacco products to anybody who is not of age. And the idea is that as time passes, because it's starting with younger people, but eventually we will have people who've grown up never having tobacco products sold in their community. Anybody? There's Maureen. You want to say something, Maureen?
Yeah, I just want to say thank you, Marian, and thank you for your support over the years with all of the tobacco prevention policies that we've adopted way back when we did 21 before the state did it. And also, I want to shout out to the state legislators who have also been very supportive and have passed important state legislation. But there are a lot of other communities besides communities in my region who are interested. In fact, I think there's a meeting in Northampton tonight meetings coming up in public hearing in Needham coming up. So if anybody has, a concern and interest, please reach out to me. I'm in Melrose City Hall, so my email address is mbusby@cityofmelrose.org, and would be glad to chat further about this. Thank you, Marion.
Of course, of course. Work a long time coming, and as I said, we are very fortunate, particularly across the state, but particularly here in Middlesex, to have such great legislative delegation that are such good partners with us in this work. I want to thank our speakers again. I want to thank all of you for being with us.
I don't get
Remember,
to share.
sorry.
I wanted,
Sue, yeah, sorry. Go ahead.
hi, my name is Sue Andrews. I work at Anchored in Recovery. I am the volunteer coordinator here. We are a peer-run recovery support center in Framingham, in downtown Framingham. And if you would like to refer anybody, any of your peers or someone that's in need, we're an alcohol and drug-free center. And we're at 19 Concord Street in Framingham. So I just wanted to put it out there that we're here, we're here, and we would love to help and support someone that needs it. Thank
That's
you.
how we share and get that. Right now. All right, thank you all. We will see you on October 17th for our next meeting. Thank you. Take care. Bye-bye.